EUS guided liver biopsy. What are the indications for liver biopsy? Help to clarify diagnosis through determine severity of liver damage, determine the nature and or grade of the tumor, help predict prognosis in a person with a known diagnosis, inform treatment decision, monitor disease progression or response to treatment, obtain liver for non-histological assessment, support research. What approaches are currently used to sample liver tissue? There are many approaches to acquire liver biopsy. The traditional method is percutaneous, with a complication of pain, hemorrhage, peritonitis, hypotension, infection. With the advantage, sure, it is cheap, well established, well known, the technical success required. The second one is transjugular liver biopsy, which may be indicated mainly in the cases of coagulopathy. The surgery through laparoscopic in patient undergoing surgery may be indicated for liver biopsy, so we can take liver biopsy during the surgical procedure. The newest method is ultrasound guided liver biopsy. The indication mainly indicated in a patient who used both liver biopsy and endoscopic procedure. For example, patient with upper abdominal pain, and we investigate for the cause by endoscope. We may obtain liver biopsy through during examination. We have a minimal complication, hemorrhage, abdominal pain, and infection. But great advantage, the increased tolerability, decreased recovery time, decreased complication, bilobar access, decreased sampling variability, view anatomical and vascular structure. Now we will demonstrate EUS guided liver biopsy technique using a standard EUS needle, which come with 3 different sizes: 19 gauge needle, 22 gauge needle, 25. The needle has needle knob and sheath knob. For example, when the needle knob on number 4, the needle will extend it 4 centimeters when the needle is pushed down. The needle has plastic sheath with rounded tip on the distal end to prevent damage to the scope working channel during insertion. There is a stainless steel construction of the tip of the end with sharp tip to allow smooth puncture to the target lesion. The distal end also must be echogenic to enable visibility under EUS image. The sheath is designed to support smooth insertion through the endoscope working channel. Before deployment of the needle, fully turn the locking hub to secure the biopsy port of the scoop. The length of the sheath extended from the scoop can be adjusted by moving the sheath knob. It is recommended that the sheath be visible in endoscopic view to ensure that the needle will not damage the scope when it is deployed. Once the sheath is in the wanted site for sampling, the physician will pull back the stylet to sharpen the needle. Then the physician will make the first puncture to the lesion. The physician will push the needle within the lesion to acquire tissue, which may be done either by slowly pulling up the stylet, which will drag tissue in the needle, or with the suction by provided syringe. The physician may use fanning technique to sample the tissue from as much as possible from the lesion. This may be done by elevating and lowering the elevator of echo endoscope. Once the physician has finished obtaining the tissue sample, he will pull back the needle handle to withdraw out from the target area into the sheath. Then the needle can be locked position by twisting the needle by the locking knob. To detach the needle from the scope, ensure that the both needle and sheath locking knobs are secured. Then twisting the needle to unscrew the locking from the locking connection from the biopsy port. Then carefully withdraw the needle. We will demonstrate a live case for EUS guided liver biopsy. 7 years old male was referred for EUS guided liver biopsy of a liver mass visualized on CT. On EUS, there is a large mass was visualized in the left lobe of the liver. When we measuring the mass measured 8 cm by 6 cm. EUS guided biopsy of the mass was performed using 19 gauge FNB needle. A fanning technique was done. A small amount of FNB sample was prepared on the slide for rapid on-site evaluation. The remainder of the FNB sample was placed on a container containing formalin. Showing long pieces of core tissue was visualized. As we see, long core tissue was visualized. Rapid on-site evaluation revealed malignant cells, which was confirmed to be hepatocellular carcinoma on cell block.